We wanted a little word about you, about your experience in using upfront radioimmunotherapy in low-grade follicular lymphomas and how it compares with the conventional modes of chemotherapy or now immunotherapy in lymphomas.
We have a 20-year experience of radioimmunotherapy with R131 rituximab, and for the past 10 years we've been using it first line as a chemo-free therapy, and we've been gratified to have achieved very good results in that after this single radioimmunotherapy, 80% of the patients have not required any further treatment for follicular lymphoma for 10 years and are still in complete remission. So that may appear as a cure. There are 20% of patients who can be identified at 3 months on a fluorine-18 FDG PET scan, and those patients would then be likely to be candidates for adaptive therapy and could be treated earlier than the conventional ways of prognosticating, which take about a year or 2 years before you know that these patients are at risk. So it not only gives an effective and non-toxic therapy because there's no bleeding, there's no infection, there's no reason for the patient to be admitted to hospital, and there's the complications compared with conventional therapies such as with bendamustine and with other toxic chemotherapies, especially long-term, contributing to the patient's quality of life. And incidentally, the I-131 rituximab treatment is a lot less expensive than the more toxic therapies.
Wonderful. So, Professor Dr. Chaudhary, you are at the front runner, one of the front runners for theranostics in India. And do you think India is going to be at the forefront of using iodine-labeled rituximab, or for that matter, nuclear theranostics in lymphoma? What do you think? Are we placed in terms of skill development, in terms of our medical oncologists being receptive towards these therapies, and in terms of developing clinical trials for the use of theranostics in lymphoma?
I think we are very nicely poised, and we have the expertise, we have the radionuclides, and with the help from people like Harvey, we can actually develop our skills and go a long way. As long as the receptivity of a medical oncologist is concerned, at least I can say in my institution, you need to pester them, talk to them, and once they are convinced, I think sky is the limit. So I personally feel we have a very good future in radioimmunotherapy of lymphomas, and how we gave a talk today, at least the medical oncologists, and fortunately one of my institute medical oncologists were also there. So they are very well convinced, and even he said that he is ready to try it out as a first line. So we need to take it from there. I think we have a future. Yes.
And there's a bigger picture, because Partha is the president-elect of the World Association of Radionuclide and Molecular Therapy. I'm a past president, and India can lead the world in Asia in promulgating this treatment throughout the Asian country through the auspices of work.
Wonderful. Thank you so much, Professor Turner and Dr. Chaudhary. I think encouraging days for us and encouraging days for the patients, where we can actually develop better protocols which will not just focus on the overall survival and the progression-free survival, but also very importantly on the quality of life. These are indolent lymphomas, and the treatment should actually improve the quality of life rather than reduce it. I mean, that is my feeling, and I think this is something which is an important takeaway from Professor Harvey's lecture today. So thank you very much.
Thank you.
Thank you.
Thanks.